He is the founder of FAVMI, and we have speakers Dr. Alok Kulkarni, Dr. Madan Balakrishnan, and Miss Dr. Kaneeca Ninawe. So we'll start the session. So I just a warm welcome to you all again, and I just wanted to introduce Miss Saraswathi Suresh. She is the founder of FAVMI, Family Voices on Mental Illness, along with me. She's a family carer to her son, who lives with schizophrenia since the last 11 years and has been navigating it through the entire mental health spectrum. Through FAVMI, Saraswati advocates for the rights and well being of family carers while working to empower families to build resilience and find hope in the caregiver journey. So thank you very much. Thank you all for rejoining this session after a short break. So we have Ms. Saraswathi Suresh from FAVMI and our speakers, Dr. Kaneeca Ninawe, Dr. Alok Kulkarni, and Dr. Madan Balakrishnan. So over to you, Saraswati.
Thank you, Sachin. To start this session, which is on types of bipolar disorder and the research breakthroughs on it. Our first speaker will be Dr. Kaneeca Ninawe. To introduce her, she is an experienced and licensed clinical psychologist with over 17 years of practice. She holds a master's degree in clinical psychology, a postgraduate in counseling psychology, and she's a NET qualified MUHS approved professor of psychology. She's earned her MPhil in clinical psychology and she's registered with the Rehabilitation Council of India, which is RCI. She's also done a doctorate in health system studies from TIS, and her study was titled A Study of Cognitions and Metacognitions in Patients Diagnosed with OCD in an Indian Sample. She's been a dedicated professional at King Edward Memorial Hospital with previous roles at Messina Hospital. She's also a certified practitioner of integral somatic psychology, which brings a holistic approach to her practice. Over to you, Dr. Kaneeca. Thank you for joining on our short conference today. We'll start with your thoughts on bipolar and the research breakthrough, which is there.
Thank you so much for such a warm welcome. I'd like to share a PPT, so I'm just going to do that. Give me a moment.
Yes, please.
We'll just begin with...
Yeah.
Yes. So, yes. So I wanted to, I thought I was going to be third in the list, so I haven't covered a lot of what bipolar disorder is, etc. But just to begin with, bipolar disorder is a chronic mood disorder characterized by the alternating episodes of mania or hypomania and depression. So what is mania, hypomania, where there's like a lot of exaggerated, elevated mood. There's a lot of libido, a lot of energy. Some patients may not require even sleep or food. So on the other spectrum, there can be a lot of irritability, frustration, because their thoughts are running faster than what they can actually do. So that they feel like everybody else is going around too slow, right? So that is the mania, hypomania. There can also be a lot of excessive spending, a lot of over talking, exaggerated sense of self. I am someone very important. I'm someone very great. That sort of thought process. And when they crash, they go into clinical depression, wherein there is extremely low mood, crying spells, not able to get themselves to do anything. So the motivation is very poor. The appetite and sleep again can get very disturbed. They tend to withdraw, don't want to talk, become socially isolated. And the feeling of, hopelessness, helplessness, worthlessness, that nothing is ever going to change. I'm not good for anything. That sort of a thought process. So it's kind of oscillating between these two extreme moods, which is the most difficult part of this disorder, which is generally quite chronic in nature. So in terms of treatment, of course, there is pharmacotherapy, which is mainly mood stabilizers and atypical antipsychotics. I'm sure the other psychiatrists will shed some light on that. And of course, there is psychotherapy and lifestyle management, which play a very crucial role in reducing relapse, improving functioning, and enhancing the quality of life of our patients, which is what I'm going to focus on in this conversation. So, one of the first sort of psychotherapies that has an immense amount of research evidence is cognitive behavioral therapy. So it helps individuals to identify and modify distorted thinking patterns and maladaptive behaviors that contribute to mood instability. The focus of cognitive behavior therapy is understanding what sort of thought processes are occurring in an individual and how they're perceiving certain events, what are the meanings they're attaching to these events, and as a result of which, what are the consequent emotions and behaviors. So, the entire focus of the therapy is trying to understand what is the thought pattern, what are the cognitive distortions, as we call them, whether it is all or none thinking, whether it is over exaggeration, over generalization, personalization, catastrophization, whatever is happening with the patient. Because let's take an example, let's say of depression, right? Even a small trigger can be perceived as a total failure. Like, for example, I don't pass one exam. For a person who's depressed, they may look at it as total failure. I'm good at nothing. I cannot do anything ever. And this sort of thinking is going to further bring them down and keep perpetuating the depressive cycle. So, in this type of therapy, what we do is we look at the thoughts and we try to change them. The focus areas involve recognizing early warning signs, both of mania and depression, developing coping strategies for stress and interpersonal conflicts, because both, when the moods are very high and very low, what happens is, in depression, people tend to withdraw. In mania, people tend to overtalk. In both the situations, what is happening is that the interpersonal communications are getting some way or the other disturbed or disrupted, causing, conflicts, misunderstandings, haggles, etc. So also CBT, we learn to teach them strategies around how to do that. Third, I already mentioned, challenging the cognitive distortions such as all and none thinking. And lastly, promoting medication adherence, because bipolar disorder is a clinical disorder. It is not going to go away by itself. It's not just, someday you wake up in like a happy mood, or someday you just wake up feeling, it's too blue, it's too gloomy, let me go back to sleep. It's not that. It's a clinical sort of situation, and it doesn't move by itself. Simply doing exercise or having a cup of coffee is not going to shake it off. There is going to be a genuine requirement for psychiatric medication in most cases of bipolar, and in CBT we ensure that there is medication adherence because we want the patient to get better. A lot of evidence has been collected, and studies have shown that CBT reduces the relapse rates as well as improves medication compliance. And that is why this is one of the first choice that is used, especially if it is a depressive episode in a bipolar disorder. The next we're going to talk about is the interpersonal and social rhythm therapy. This was specifically developed for bipolar disorder by a person called Ellen Frank, and it emphasizes stabilizing daily routines and the sleep-wake cycles to maintain circadian rhythm stability. So the goals are regularizing the social and biological rhythms. For example, sleeping at a particular time, waking up at a particular time, sleeping for a certain amount of time, eating meals that are specific at a certain time, adding exercise into the schedule, and having specific structured social activities. The focus of this entire therapy is in some sort of structure, whether it is in terms of our circadian rhythm or whether it is in terms of our social interactions. So it focuses on managing interpersonal stressors that trigger an episode, and also obviously enhancing medication adherence. So what is seen is that the more structure we provide to our patients, the better they are able to get out of bipolar. Because, for example, when you are hypomanic or manic, there's a lot of energy in the patient wants to do a lot more and can do a lot more. Like, we've had patients who've been able to finish off a week's work in a day because they've had that sort of energy. They've not slept through the night and they're not feeling anything about it, right? But what it's doing is, eventually our body has a specific amount of energy that's available to it, and eventually when the crash happens, it's going to even biologically affect the client. So we have to explain to the client who has bipolar all of these things, and even if there is mania, we have to ask them to cut down. So even that is difficult because they want to do so much more. Finally, after that depressive episode, when they're feeling all blah and low, when the energy begins to build, people want to experience it. They feel happy about finally seeing the sunlight. But even in those situations, we have to figure out a window of tolerance and try to maintain them within that window of tolerance. So this therapy is specifically looking at that, and it has been shown to delay recurrence and improve overall functioning in individuals with bipolar disorder. The next is family-focused therapy. Especially in a country like India, I think family becomes a very important component of therapy in any disorder, including bipolar disorder. And FFT involves the patient and their family members in psychoeducation, communication enhancement, and problem-solving training. So the key components are, very importantly, psychoeducation about the nature and course of the bipolar disorder to both the patient as well as the caregivers, and training in constructive communication and conflict resolution. Because what happens is, a lot of times families don't understand how to react to the patients when they're having an episode. So in FFT, we train the caregivers in how they can communicate more effectively with the patients. The focus is a lot on trying to reduce expressed emotion. So what is expressed emotion? Expressed emotion is the sort of emotion that is expressed to the patient by the family at large. So there are different kinds. For example, one is critical comments. A lot of the families can become very critical of the patients because obviously in mania, the patient may have gone berserk, they may have spent a lot of money, they may have, acted in disinhibited fashion. So now when the patient has taken medication and is kind of, in a managed zone, a lot of families tend to pass critical comments about what has happened. Oh, you did this, you did that, we had to suffer so much loss, XYZ. And although it is reality, what it does is it pushes the patient further down. And, it's going to impact the patient negatively, is what research suggests. And therefore, it's important that they are not constantly criticized for what has happened in an episode, because it is out of their control. The way the dopamine and serotonin are kind of interacting with each other is not in the voluntary control of the patient. So we have to understand that, and that is exactly why we have to withhold excessive critical comments. The other is hostility. A lot of patients are met with hostility in behavior, aggressive, like hitting, etc., which is also to be curtailed. There's another form of expressed emotion, we call that emotional over-involvement, where, you start to think that, okay, now this is a patient, the patient has a label, and so now the patient is incapacitated. So we have to kind of go all out and do extra, oh my God, you're back from the OPD or the hospital, or, if they've had any sort of more intensive treatments like ECT, etc., almost start teaching or almost start treating the patient like they're a child, right? So don't do this, don't go here, don't go there, follow them everywhere, provide them everything in their hand. In any decisions they're making, they're not given that independence because they feel, they will make a wrong decision. So the caregivers are constantly engaging themselves. So all of these are what we call maladaptive expressed emotions, which is what is discussed in the family-focused treatment. And the last expressed emotion, that is what we call a productive expressed emotion, is called warmth, right? Where we express our love and concern for the patient in not in an overly mollycoddling way, just in a normal way, how you would to all the other family members. So that is what is focused here. And if you look at the outcomes in terms of research, FFT has shown to reduce relapse rates and hospitalizations just as other treatments have. So it's a very important component of whether we are doing CBT or whether we are doing interpersonal and rhythm. We will definitely be bringing in the family element. And especially in a country like ours, where the patient is going to go back to family, is going to be a very important component. Psychoeducation, though it seems like the most, it's like, it's not a given, it's a thing that has to happen, but it's a very, very important component of any sort of treatment. It involves providing patients and families with information about the treatment, about the illness, about medication adherence, about lifestyle regulation. Because if the patient is not psychoeducated, the insight is not built, what will happen? Patient is not going to be able to identify early symptoms. So when minor things start to happen, when the circadian rhythms are changing, appetites are changing, these are your first few symptoms, even before like the mood and the behavior is setting in. And we want the patient to be able to identify that, so that immediately they can go back to the treatment provider and ask for a change in medication or therapy or whatever that is required. So that's very important. Second is the importance of medication adherence is not going to be there unless they understand the nature of their illness completely. So it's very important that a lot of time is spent with the patient to help them understand their illness, what exactly are their symptoms, how they are manifested, and how they affect themselves, their family, and society sometimes. So all of this is done. Sleep hygiene and daily routine stabilization again is focused here, and stress management and relapse prevention strategies are also discussed. So it enhances the insight, empowers the patients to take an active role in managing their illness. And it has been seen in a lot of studies that patients who have insight and who are positively engaged in their treatment tend to heal faster and have typically less relapse rates as compared to patients who do not. Now what we see commonly, coming up, the newer therapies that we call the third wave cognitive therapies are the mindfulness-based cognitive behavior therapy and acceptance and commitment therapy. These help to improve emotional regulation and reduce rumination. So the focus is cultivating non-judgmental awareness of the mood fluctuations, not to attach any meaning to the symptoms. Oh my God, now this, I'm going to have a manic episode. Now it's going to be a breakdown. I'm going to go crazy, etc. These are the meanings we're attaching to symptoms as patients a lot of times. So we're trying to cultivate a non-judgmental awareness that, okay, this is a disorder. To kind of look at it from a third person perspective so that they're better able to manage it. Accepting emotional experiences without impulsive reactions. Okay, it's okay for me to sense a particular emotion. I don't have to act upon it impulsively, especially in a manic episode. And then developing psychological flexibility to manage bipolar symptoms, because adaptability is a very important tool when it comes to this disorder, because it doesn't adhere to one specific set of symptoms, right? So this is what we want to develop with the acceptance and commitment therapy, and it has shown to reduce depressive relapse and improved well-being. Lastly, lifestyle modifications, very important. Sleep hygiene. So sleeping at least 8 hours a day, whether you're depressed or manic. Sleeping at a certain time. It's very important that the medication is taken early on, so the patients also sleep early on. Just sleeping 8 hours is not enough. Sleeping at 2 in the night and then waking up later is not the same as sleeping at 10:30, 11 and waking up at a certain time. The initial first sleep cycle is a very important sleep cycle, which should not be missed by not just patients, even all of us. Second, of course, is regular exercise. Exercise helps all the other treatments. So it's like creating the safety net for the client to do all the other medication adherence and treatment work. So light exercise, even it's 30 minutes, 3-4 times a week is also a good idea, but that needs to happen. What happens with exercise is that it activates your vagus nerve. Vagus nerve is a nerve that goes from your brain to every internal organ in the body. And when this nerve is activated, what happens? There is better emotional regulation, which is why regular exercise is a good idea. Healthy diet, of course, a good amount of nutrition, omega-3 consumption helps in maintaining the moods. Stress management, a lot of patients are now taught deep breathing, belly breathing, progressive muscular relaxation. And these are good strategies to counter everyday stressors, because even if there is not, let's say, a big high and low, there are going to be stressors. Simple things like, taking a train, reaching a workplace is a stress in a place like Mumbai. So, you don't want to get stressed about it. So simple stress management techniques are taught and can be learned not just by patients, but all of us caregivers also, because caregiving also can be very strenuous. So this is a good idea. Structured daily routine, we already discussed this, helps the patients to remain in the window of tolerance. Social support and communication to engage in society. So just because there is a disorder, we don't have to shun our patients and kind of say we don't know how we will react, let's say, in a social situation, so let's keep them isolated, because that's going to further isolate them and further perpetuate the cycle. So we want them to be included in, let's say, there's a marriage or there are guests coming over, etc. We want the patient to be engaging when this happens. And avoidance of triggers. So this is trying to understand what are the things that will trigger an episode, whether it's a fight, whether it is loud sounds, whether it is a particular sort of lack or loss of person. We have to identify these triggers and try to avoid them if we can. So just to conclude, psychotherapy and lifestyle modifications are indispensable adjuncts to pharmacological treatment in bipolar disorder. And while medication manages biological symptoms, psychotherapeutic interventions, they enhance emotional regulation, insight, and coping skills. Lifestyle regulation stabilizes biological rhythms and prevents relapse. An integrated biopsychosocial approach thus yields the best long-term outcomes in managing bipolar disorder. Thank you.
Thank you, Dr. Kaneenica. That was very, very informative. And I'm sure let's take this forward by listening to the next speaker, that is Dr. Alok Kulkarni. Dr. Alok is a distinguished interventional psychiatrist from Hubli, Karnataka. He has done his extensive training in from NIMHANS, Bangalore. He was part of India's first government-funded telepsychiatry program and later became member of the Royal College of Psychiatrists UK after excelling in its rigorous examination. He specializes in non-invasive brain stimulation techniques, including TDCS, RTMS, and ECT, and is a recognized voice in the national and international media advocating for mental health. He consults presently at the Manas Institute of Mental Health and Neurosciences, a premier center for treatment of mood disorders at Hubli in Karnataka. Over to you, Dr. Alok.
Thank you, Dr. Saraswathi. Thank FAVMI for giving me this opportunity. FAVMI has been very kind in providing me with such opportunities. I've borrowed all of my content from this platform called Neurotorium. It's by Lundbeck Foundation. And I would encourage today's audience to refer to these resources, because it has a lot of patient education material and family education material as well. I'll quickly run through the slides without going into much of the details and specifics and nuances, because I'm sure today's audience is a very well-informed and educated audience, and the previous two speakers have spoken very comprehensively on bipolar disorder. So bipolar disorder is a chronic mood disorder which affects around 1% of the global population. If you work out the numbers for India, it's around 60 to 70 lakhs. Although 1% looks like a very small number, if you work out the numbers in relation to India's population, that comes to around 60 to 70 lakhs. And the prevalent treatment gap is around 70% for bipolar disorders, as per NMHS 2015-16. So there are many types of bipolar disorder. As you would all be knowing, bipolar 1 is characterized by mania and depression, whereas bipolar 2 is characterized by hypomania, and various classificatory systems that are available. We have the Diagnostic and Statistical Manual, we have the International Classification of Disorders, and so on and so forth. But ultimately, it is a clinical diagnosis at the end of the day, and you will have the clinician, the mental health professionals will have to sit with the patient and the patient's family and chart out the longitudinal history of the clinical symptoms to arrive at a diagnosis. One of the things with bipolar disorder is that there's a lot of overlap with other comorbidities such as ADHD, personality pathology, major depressive disorder, and so on and so forth. So coming to a conclusive diagnosis is a challenge because of the absence of availability of biomarkers. There are no lab tests or brain scans that can diagnose bipolar disorder as of today. So one study estimated that it takes almost 7 to 10 years to come to a diagnosis of bipolar disorder. And this is partly because the index mood episode, the presenting episode, is more often than not a depressive episode, and hypomania or mania gets missed. Mania may not get missed, but hypomania does get missed a lot of the times. Due to various reasons, because the patients may enjoy the elevated mood. Some patients may lack insight during hypomania or mania. There are so many reasons, and it takes a good 7 to 10 years to arrive at the diagnosis. And unfortunately, by that time, structural and functional changes in the brain would have occurred. So we will have to arrest the disease as early as possible to prevent neuroprogression. Now, there are various terms. I would want to draw your attention to hypomania and mania. Mania is a state of mind characterized by excessive cheerfulness and increased activity. The patient's mood is elevated, euphoric, or even irritable. Hypomania is a mild degree of mania. One of the things that I want to draw your attention to is the fact that just because hypomania is a milder form of mania, it doesn't mean that the depressive episodes prevalent in type 2 bipolar disorder are any less disabling. In fact, studies have shown that the depressive episodes of bipolar 2 disorder can be worse and significantly bad as compared to bipolar 1 disorder. And the suicide rates, morbidity, and mortality are even worse for patients with people with bipolar type 2 disorder. Then we have other terms such as cyclothymia, dysthymia. Mania can happen with a state called psychosis, wherein the person loses touch with reality. Patients can have delusions, hallucinations, and so on and so forth. When we talk about bipolar disorder, it is a chronic mood disorder. So when I say chronic, we should be aware of other medical disorders such as diabetes, hypertension, dyslipidemia, thyroid dysfunction, and coronary artery disease. These disorders are also chronic in nature. So it will require long-term medication management, long-term psychosocial management. Management is applicable to bipolar disorder. We always conceptualize bipolar disorder as a chronic mood disorder existing on a continuum or existing on a spectrum. On one end of the spectrum, we have unipolar depression, dysthymia, subthreshold depression, and on the other end of the spectrum, we have mania, hypomania, and unipolar mania, although that is extremely rare in clinical practice. It's useful to conceptualize the illness as existing on a continuum or on a spectrum. Bipolar disorder has had a long history, a checkered history, in fact. Hippocrates was among the first to document two extreme modes as early as 370 BC. Earlier, it was known as manic depressive psychosis or manic depressive insanity. Curative in nature, quite derogatory in nature, and it does disservice to people who experience bipolar disorder and to the families who have to deal with bipolar disorder. The term manic depressive psychosis actually applied to any mood episode which was recurrent in nature. For example, if a person had 2, 3, or 4 episodes of depression, it would still be classified as manic depressive psychosis or manic depressive insanity. The term referred to the recurrence of the mood episodes and not to the polarity. This was how Emil Kraepelin sort of conceptualized the disorder, and he labeled it as dementia precox. It was prescient because we now see that modern neuroscience has shown that there are a lot of cognitive impairments that can occur in severe mental illness, such as schizophrenia and bipolar disorder. With the introduction of DSM-3, the term manic depressive insanity was replaced with bipolar disorder. Now, speaking broadly, as I spoke in the beginning, 1% of the global population has bipolar disorder. Now, there are various numbers. This is Western literature. The numbers might differ with respect to Indian literature. But if you were to remember one number from today's talk, I think 1% of the population has bipolar disorder, and that is a huge number. So we have various other numbers, bipolar 4, bipolar 1, bipolar 2, and subthreshold bipolar disorder. This was a classic study which came out in 2011, published in the Archives of General Psychiatry by Malkingas and colleagues. Now, there are various risk factors that are applicable to bipolar disorder. Broadly, the age of onset is between the ages of 15 and 30 years. And that is what is so disheartening and cruel about this disorder, because that is the prime area of a person's life. That is when there will be a lot of personality development. That is when a lot of productivity and gainful employment takes place. And unfortunately, disorders like schizophrenia and bipolar disorder sort of manifest between late adolescence and early adulthood. So that is why the current focus of the field is on earlier intervention, to identify the diagnosis earlier so that we can arrest the progressive brain changes. There are a lot of risk factors that may increase the risk of bipolar disorder. Doesn't necessarily mean that if you have these risk factors, you will definitely manifest the disorder. We can think of these factors as factors that increase the risk as compared to somebody who does not have these risk factors. So some of these include childhood maltreatment, such as neglect, domestic abuse, sexual abuse. So I want to spend a few minutes on this. In my clinical practice, I've seen that people who have been victims of childhood maltreatment do not respond as well who have not had childhood maltreatment, not just in bipolar disorder, but across psychiatric diagnosis. So it's very important to provide a stable environment, a stable childhood environment. A lot of it may not be under our control, but to the extent possible, it's important to provide a stable environment. And study after study has shown that there's a suboptimal response to treatment. if there is coexisting childhood maltreatment. So psychological stressors, psychosocial stressors play a huge role in the causation and in the overall treatment outcomes. We can keep talking about a lot of biology, we can keep talking about a lot of neuroscience, but the psychosocial factors play a huge role. Then there are other risk factors such as family history of bipolar disorder, substance misuse. Currently in my practice, I'm seeing a lot of cannabis that is being used and that is predating the onset of severe mental illnesses, especially bipolar disorder. Now, there's an established link between creative genius and bipolar disorder. If you look at the history, a lot of to go through bipolar disorder or other mood disorders. So we spoke about global burden. Now, the unmet treatment gap in India is around 70%, which means to say that 70% of the people require treatment, but they are not having access to resources for treatment of bipolar disorder. Now, what's the impact on patients and patient families? So it's a difficult diagnosis to accept. It's not easy to accept that you will have to be on medications for a long period of time. Now contrast that with diabetes or hypertension, coronary artery disease, thyroid dysfunction, or dyslipidemia. It's somehow easier to accept that, okay, I've got diabetes, I may need to be on medications for some time and maybe indefinitely. Unfortunately, that has not percolated to psychiatric disorders or to mental health disorders. And to my mind, that is partly because there's the overall personality can get affected when the person is in the midst of a mood episode. There might be irritability, there might be disinhibition, which is not seen with other disorders such as diabetes and so on and so forth. So that can have a lasting impact on the patient and the patient's family. It can impact relationships. There can be loss of autonomy. There can be a lot of uncertainty. Stigma is still prevalent even in 2025, and organizations like FAVMI and all stakeholders need to do a lot more to reduce the stigma associated with bipolar disorder. But at the end of the day, I know a lot of people who have gone on to achieve great things. Even I have a lot of personal contacts. I have a lot of patients who have bipolar disorder but are gainfully employed, have done wonderful things in their lives. So there is hope. Even though it can be a disabling disorder, I want to reassure that there is hope. Now, there are a lot of strengths and positive characteristics that we can identify, such as increased empathy, increased creativity, increased self-awareness, increased productivity, increased self-confidence, this feeling of being invincible, enhanced relationships with friends and family, heightened ability to appreciate other things, and heightened experiences. It's very important to take into consideration these positive strengths and characteristics of the patient while working with the patient as far as psychosocial management is concerned. And it's very important for the clinician to instill a sense of hope in the patient and also the patient's families. We are all familiar with diagnostic criteria. I will not go into this because I'm sure the previous speakers have delved enough into this. I quickly run through it. So mania is characterized by increased psychomotor activity, and some of the core features include inflated sense of self-esteem or grandiosity, decreased need for sleep, patient being more talkative than usual with pressured speech, and we cannot interrupt when the person is speaking, flight of ideas or experience that thoughts are racing in the patient's mind. The person can be easily distractible. There is increased goal-directed activity, and this in turn gives rise to increased productivity, excessive involvement in activities that have a high potential for painful consequences, such as risky spending or risky sex, and so, or excessive shopping, and so on and so forth. So the mood disturbance should cause socio-occupational dysfunction, and the mood disturbance cannot be attributable to the physiological effects of a substance such as cocaine, alcohol, or cannabis, and so on and so forth, or to other medical conditions such as organic brain disorder or the usage of steroid, etc. Now, hypomania, as I said, is a milder form of mania. The key distinguishing feature is that hypomania will not cause socio-occupational dysfunction. It will not result in inpatient hospitalization, and psychotic features are absent during a hypomanic episode. Similarly, major depressive episode, beyond these classificatory systems, clinical interview is of utmost importance in diagnosing any mood episode. So depressive episode is characterized by depressed mood for most part of the day or for a majority of the day, anhedonia, that is markedly diminished interest in activities that were previously pleasurable, significant weight loss or weight gain, or changes in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, hopelessness, inappropriate guilt, diminished ability to think or concentrate, recurrent thoughts of death, suicidal ideation, suicidal plan or suicide attempt. So these are the features of a major depressive episode. Now there are various specifiers. This is more of academic interest, so I will not go into that. But one of the things that I want to draw your attention is to the presence of mixed features, because this not only delays diagnosis, it can also result in a suboptimal response to treatment. So mixed features is one category wherein features of both depression and mania can be present at the same time, and it is quite challenging to diagnose, and it can be quite challenging to manage as well. Now, there has been an evolution in the understanding of mixed features, and our understanding continues to evolve. This is not set in stone, because as you would be knowing, a group of experts come together and then decide upon the most prevalent clinical characteristics for any disorder. So this will keep changing, and we will have to make peace with that until and unless our field moves towards biomarkers. But it is not inherently easy to come up with biomarkers in psychiatry, because psychiatric disorders are inherently heterogeneous. They are polygenic, meaning to say that a lot of genes are involved, and they're heterogeneous in nature. They're inherently complex. They have a higher wall to climb as far as severe mental illness is concerned. Now, bipolar disorder 1 and bipolar disorder 2 differ in terms of symptom severity. Two prospective longitudinal studies investigated the symptomatic status of patients with both BD1 and BD2. In these studies, the longitudinal course of BD1 and BD2 was chronic and was dominated by depressive symptoms. As I was saying, this is Western data, this is Western literature. The PGI Chandigarh study, Indian literature study, has shown us that more often than not, the first presenting episode in Indian population is one of mania or hypomania. Now, we also talk about subthreshold bipolar disorder, wherein the symptoms do not meet the diagnostic criteria of either depression or mania. Now, there are differences, similarities, and dissimilarities between ICD-11 and DSM-5. Again, more of academic interest, so I will not delve into that. But this is one topic that I want to talk on. There's a substantial delay in the diagnosis of bipolar disorder, and this ranges from 7 to 10 years. And one of the reasons for this delay is that the physician in primary care practice is not trained well enough to pick up a diagnosis of hypomania or mania, which is precisely why our center is trying to educate the primary care physicians of North Karnataka via remote tele-mentoring, tele-education, tele-consultation on how to identify episodes of mania and hypomania, because the first point of contact is usually the primary care physician or the general practitioner. And we have recently applied for a grant and we are yet to hear from them. So the overarching idea of this project is to train the primary care physician in community practice in identifying hypomania or mania, and I'll come to that in a bit. Now, there are various factors associated with delays in diagnosis, and these include sex, younger age of onset, higher misdiagnosis, and care of the patient. Now, what is the consequence of delayed diagnosis? One of the important consequences is that it is a progressive disorder. We call that as neuroprogression, and there is plenty of literature available in this regard, most notably from Dr. Lakshmi Yatham and colleagues, wherein they have shown that the later we diagnose bipolar disorder, there are progressive brain impairments, structural and functional changes that occur. And it is of seminal importance that we arrest neuroprogression. That can only happen if we diagnose the disorder as early as possible. We need to sort of arrest the disorder by diagnosing it around the ages of 15, 16, especially in people who have a positive family history of bipolar disorder, who have had unstable childhood environments, who have other risk factors such as substance misuse. So if we can identify these individuals and if we can give them the necessary psychosocial support and educate the family and patient about their risk, educating them about steering clear of substance misuse, educating them about following sleep hygiene. The previous speaker spoke very beautifully about interpersonal social rhythm therapy, about the need of maintaining biological rhythmicity. Then there's a possibility that we can diagnose the disorder earlier, we can stabilize biological rhythms, we can give them the necessary psychosocial support, and then sort of look at least reducing the impact of the disorder on the patient and the patient's family. Now, there are a lot of differential diagnoses. There's a lot of clinical overlap and comorbidity that comes with bipolar disorder. The commonest diagnosis is major depressive disorder. The other co-occurring diagnoses include anxiety disorders, ADHD, psychosis, and substance misuse. Now, other than depression, pure depression includes the following: a positive family history of bipolar disorder, numerous past episodes of depression that have not responded to treatment. For example, we have a patient who is 18 years old, has a positive family history of bipolar disorder, presents with multiple episodes of depression, which are not responding to antidepressant first-line treatment, which are not responding to psychosocial management. And these episodes come on quickly, and they have a fast onset and a fast offset. There are presence of psychotic or manic symptoms. Then it should alert the clinician or the mental health professional towards a diagnosis of possible underlying bipolar diathesis and bipolarity. Now, there are various cultural issues in diagnosis. One of the things with the Indian culture is that to some extent, irritability can be overlooked to some extent. Educate patient families and clinicians about this. Now, there are a number of useful clinical tools to support the diagnosis and assessment in primary care practice. I would encourage all mental health professionals to use this scale called Mood Disorder Questionnaire. If you Google it, you will get it. So this is a 15-item tool that screens for a lifetime history of manic or hypomanic episodes, and it is one of the most widely used screening tools. you'll have to, there are questions numbered from 1 to 14 and they're answered in a yes or no fashion. In case the person or the family answers yes, then you can probe deeper. Question 15 is rated on a scale of 0 to 3 to know the severity of the problem. For a positive screen, 7 out of 13 items must be met, and on 2 additional items, patients must confirm that several of the symptoms have occurred during the same time period, causing moderate to serious impairment. Some of the questions include: has there ever been a period of time when you were not your usual self and you felt so good or so hyper that other people thought you were not your normal self, or you were so hyper that you got into trouble? You were so irritable that you shouted at people or started fights or arguments. You felt much more self-confident than usual. You got much less sleep than usual and found that you didn't really miss it. You were much more talkative or spoke faster than usual. Thoughts raced through your head or you couldn't slow your mind down. You had much more energy than usual. So this has a higher sensitivity in detecting BD1 than BD2. As always, BD2 is a challenge because it is not always easy to diagnose episodes of hypomania. There's a different scale for hypomania, and that's called the hypomania checklist. This has 32 items, and it is also one of the useful tools in diagnosing bipolar hypomania and bipolar type 2 disorder. Then one of the very useful scales for a clinician in primary care practices. So this has 6 items, and look at some of the questions. Have there been at least 6 different periods of time when you felt deeply depressed? Did these problems occur before the age of 18? That is a very useful pointer towards underlying bipolarity or underlying bipolar diathesis. Have you ever had to stop or change your antidepressant because it made you highly irritable or hyper? Now, again, this is a very useful clinical pointer. Patients with underlying bipolarity do not have a good treatment response to antidepressants. Some may even go on to have a very bad treatment response to antidepressants. Have you ever had a period of at least 1 week during which you were more talkative than normal with thoughts racing in your head? Essentially, it combines items from the previous scale that I talked, but it is much more succinct. Have you ever had a period of at least 1 week during which you felt any of the following: unusually happy, unusually outgoing, or unusually energetic? Have you ever had a period of at least 1 week during which you needed much less sleep than usual? Then, apart from these rapid screening tools, we also have structured diagnostic interviews, such as the structured clinical interview for diagnosis version 5, DSM-5 criteria, composite international diagnostic interview, and various other schedules which can be used in clinical practice. Then we also need to assess the symptom severity. We have clinician-rated tools and patient-rated tools. Then there are also tools available for assessment of quality of life and functioning. And this is very, very important as far as the patient's family is concerned. Now, a couple of minutes on the future of bipolar disorder diagnosis and management. There has been a very interesting study done by Mayo Clinic, which has tried to distinguish between major depressive disorder and bipolar depression using neuroimaging. But this data is again from Western population, needs more replication. For those of you who are FRYE et al. And Mayo Clinic, and depending on the concentration of lipids in the brain, can we distinguish between unipolar depression and bipolar depression? Very interesting data coming out from Mayo Clinic. They have a biobank of patients with bipolar disorder. Hopefully, it gets replicated in clinical practice. So in summary, bipolar disorder is a chronic mood disorder. We need to follow the chronic disease model of management. It can cause significant disability if diagnosed later. Childhood maltreatment is a significant risk factor. we need to educate our patients and family members to not add additional insults to injury, such as steering clear from substance misuse, such as cannabis, cocaine, and so on and so forth. We need to give our patients the necessary cycles are taking place and they continue to take place, but it's important that we adopt an integrative, holistic psychosocial management so that our patients have the best chance at an optimal outcome. With this, I'll stop sharing my slides.
Thank you, Dr. Alok. Just for the audience, Dr. Millen has got held up somewhere and wouldn't be able to join. So we'll continue with our question and answer round, Dr. Alok and Dr. Kaneenica. Just to start with both of you is, what is the new research which is available now for bipolar disorder in terms of both medication, therapies, with the digital tools available, apps, etc. Could you be able to show some light on this?
Kaneenica, you want to go first?
No, you can continue. I'll just add.
Yeah. Okay. So I'll talk about the pharmacological aspects of it. So there's a lot of research that's been happening. For example, when I was at the University of British Columbia in Vancouver in Canada, I had the opportunity to take place in a number of clinical trials, specifically with respect to the pharmacological management of bipolar disorder. Now, the various trials that are going on is the usage of cannabidiol for the management of depressive episodes of bipolar disorder, especially bipolar type 2 depression, because we don't have a lot of molecules available for the treatment of bipolar type 2 depression. So we are testing out whether cannabidiol can be an useful molecule for the management of bipolar depressive episodes. Now, with the psychedelic revolution, we have the availability of psilocybin for the management of bipolar depression. So Western data is geared towards the management of depressive episodes because their studies have shown that patients spend 3 times more time being depressed than in other mood states. So the effort naturally is then towards managing the depressive episode. So we have psilocybin, we have cannabidiol. That now there's a renewed research interest as far as anti-inflammatory molecules are concerned. For example, the routine painkillers that we take. So can they be used to manage the mood episodes in bipolar disorder? Then we also have an agent called D-cycloserine. It is actually an anti-tubercular agent. Can that be used? So this is going on in the US, and Dr. Andy Nirenberg is in charge of this. We have a newer molecule called lurasidone. Can the fixed dose combination of lurasidone with D-cycloserine, is that more effective than either molecule alone? There's a lot of newer molecules that are available. It's just that we need more randomized controlled trial data. It's just that we need more application in clinical practice, and it should be applicable in the Indian context as well.
That was my question. Is this research happening in India, any one of them?
So India has come up with a great molecule for irritable mania and for euphoria. It's called endoxifen, and it has been developed by Intas Pharmaceuticals, and it's very effective as far as irritable mania or even euphoric mania is concerned. That has allowed clinicians to reduce our dependence on antipsychotics in the management of mania. Again, India's effort is towards managing the other pole of the disorder, that is mania and all. But I can reassure today's audience that a lot of novel agents that are safe, effective, and tolerable have come out. For example, if you look at the agents that are available for the management of acute bipolar depression, we have lurasidone, we have cariprazine, we have olanzapine fluoxetine combination, we have quetiapine, we have lamotrigine, and then a lot many agents such as cannabidiol, psilocybin, although they are not FDA approved currently. So a number of molecules are available.
Dr. Kani.
He's given us such amazing range of medical and biological treatments in terms of research. What I see in terms of therapy and also in terms of screening, I think a lot of researchers, I know two of them personally, who are trying to build AI softwares or chatbots for early screening. So because a lot of times, like Dr. Alok already said, that the hypomanic symptoms kind of don't get picked on very easily. So they're trying to develop, I think, more chatbots or AI sort of applications where early screening can take place so that those patients can be then sent for more intensive treatments to hospitals. So that's one thing that I know is currently happening. In terms of psychotherapy, I think a lot of interactive therapies and integrating them together is what's happening now. Like nobody really does just one, let's say only interpersonal or only CBT. So a lot of eclectic approaches are trying to be coming up, and integrative practices are something that's more commonly seen for now. Yeah.
Just to take a few questions from the chat box. One question is, what about money management? How to explain that they are being controlled on financial decision, especially when it's the mania state, and how to manage the conflict between carer and patients?
Yeah, so I think, like I said earlier, one of the major therapeutic parts besides pharmacology is psychoeducation. So it is very important that a lot of time is spent with the client to explain to them what exactly is the nature of the illness. And once they understand that the spending or overspending, as we can see, is coming out of a disorder, it's not something that they're doing voluntarily, meaning if there was no disorder, they'd probably not engage in a behavior like that. Once they understand that, then it becomes easier to explain to them why we are curtailing their access to, let's say, a lot of credit cards. That's what we say. We try to, curtail their access to things like that so that there is the opportunity for overspending is reduced. But it will only seem like a sort of jailing for the patient if they're not understanding why that is done. So it's very important that when they are in their lucid state, when the pharmacology has worked and they are more aware of what's happening, that we build this insight into the disorder. I think that really helps.
So the next question is on insight itself, which is the term used by all professionals. Can you elaborate what is insight? Dr. Alok, would you like to take that question?
Yeah. So insight is the appreciation of the fact that I may be unwell during an episode. And it's so in severe mental illness, especially schizophrenia, wherein the patient has lost touch with reality. The patient may be hearing voices, may be delusional, thinking that others are talking about matters related to him or her, or the patient may be suspicious of others' motives and intent. Insight may not necessarily be present. So one of the goals of therapy during that period is insight facilitation, as and duly supported by psychopharmacological management. And once the patient gets better, once the patient gets well, the patient is then able to appreciate the fact that, yes, maybe I was unwell a couple of days back, something had happened, I was not able to appreciate my environment, my surroundings. Maybe I lost touch with reality, but now I am better, and I may need to stick on to treatment and psychosocial management in the coming days. So that is what is basically insight.
Would you like to add, Dr.
Yeah.
Yeah, so there are a number of levels of insight as we see, and what we see is that when somebody is having an acute breakdown, there obviously the insight is absent, so level 1. But as and when the treatment begins and they are, becoming more and more towards reality, they're understanding what's happening, their symptoms have come down, then you see that they can move ahead. And in that sense, what we want them to reach is the level 6, which is the emotional insight, where they understand that they have a disorder, what are the causes of the disorder, and that they need to be proactively involved in the treatment of the disorder. So that's where we want to move the patient towards, and both the medical and psychological treatment is geared towards that.
Okay, the next question is dyscalculia responsible for developing bipolar disorder?
Do you mean dyscalculia?
Dyscalculia, yeah, I'm sorry. Dyscalculia.
Dyscalculia, I haven't read research suggesting that it's responsible for bipolar, but I think Dr. Alok could be better at.
Yeah, as Dr. Kaneenica mentioned, I don't think there's any literature support to say that dyscalculia is directly responsible for the causation of bipolar disorder. I think it is, those two are very different constructs. Yeah.
Okay. How do we differentiate between bipolar disorder and schizophrenia?
Do you want to go, Dr. Alok?
Maybe can tell, and probably then I can add on.
Okay, so bipolar and schizophrenia, again with schizophrenia, the basic symptoms are to deal with loss of touch with reality, which means that there is presence of hallucinations, delusions, and disorganized behavior. Disorganized behavior can also be seen in bipolar because of the mood elevation. There may or may not be a psychotic element of delusions or hallucinations that are involved. So I think that the mood is the basic differentiating factor, especially when mania is concerned. Now, with the negative symptoms of schizophrenia, there's a bit of difficulty there, because depressive symptoms can seem to overlap, like avolition, etc., can seem to overlap with the depressive part of the bipolar, but that is essentially a depressive episode only. So when there is that depression along with the manic, that's when it becomes bipolar. But even then, the mood is the major component, whilst in schizophrenia, the loss of touch with reality, I think that is the major component. Would you like to add, Dr. Alok?
Yeah, I think Dr. Kaneenica has covered it very nicely. So, as she had mentioned, bipolar disorder concerns 3 elements, such as mood, energy, and activity levels. Any disruption in these 3 components tends towards bipolar disorder. For example, in mania, we have elevated mood, increased energy levels, and enhanced activity levels. Whereas the opposite end of the spectrum, in depression, we have low mood, easy fatigability, and low activity levels. Basically, along with mood, bipolar disorder also concerns with energy and activity levels. That is how the disorder has been historically conceptualized. If you look at a person with endogenous depression or melancholic depression, the manner in which the person talks, the tone, tempo, and volume of the speech will be low. He may not come across as being very energetic, and there might be slowness in the psychomotor components of the person. For example, he may be slow to talk, he may be slow to walk. So mood, energy, and activity levels are the principal constructs that are affected in bipolar disorder, whereas in schizophrenia, it has got to do more with delusions, hallucinations, and disorganized speech. A false, unshakable belief that others are out to get me, or that my thoughts are being heard by others, or that I'm hearing voices when no one's around. So these are the kind of symptoms that are seen in schizophrenia. But at the same time, there's a lot of overlap. It may not be very easy to distinguish between these 2 states. There's a lot of overlap that can occur between schizophrenia and bipolar disorder. And schizophrenia is a progressive disorder. It has its onset between 18, 19, 20, and the overall personality functioning can get affected in schizophrenia. There may be deterioration in the personality in schizophrenia, which is not the case in bipolar disorder. The overall personality is preserved in bipolar disorder.
Okay. Just the last two questions to both of you. One is, in maniac conditions, are there any symptoms where a person does work beyond one's capacity without delegation of work, prioritization, even to a point of not eating food on time?
Yeah, of course. That is definitely possible. And that is exactly the problem with mania, that they don't even realize that they're, doing so much, because there's so much energy available at that time that they would want to do that. Yeah.
And there's another person who's asked on the role and use of AI in mental illness, which you have already spoken, but would you like to add on to anything that you'll have already spoken on, and your last few words on this topic?
So the only issue with AI that we've seen in terms of a negative issue is what's been happening with the OpenAI and ChatGPT, where now people are just typing into the chatbot their problems. Now chatbot is obviously not a mental health professional, so it's giving back whatever in terms of a code, whatever is coming up. And quite clearly there have been cases where I think somebody asked how to not feel suicidal, or what to do if I'm feeling suicidal, and the chatbot actually gave out how to commit a suicide. The person really committed and died. So that is an essential danger when it comes to AI, because it's not regulated yet, and there is no sort of way to know what people are typing in and what is the sort of response that's coming out. So it may definitely be helpful to a certain extent, but these dangers for now seem quite scary because they're unregulated.
Yeah. Dr. Alok, last few words.
Yeah. So bipolar disorder can be disabling in nature, but at the same time, I know of family members and friends who have gone on to lead exceptionally productive lives with bipolar disorder. During the throes of a mood episode, it can get scary, but there is endless hope that is available with the advent of newer treatments, both pharmacological treatment and psychosocial treatments. It's important to be a bit patient, because not every molecule may work in every single person. For example, lithium works beautifully in a majority of people, but in a minority, it may not work. So please be patient. And I see a lot of comments online wherein I see that the clinician has been very rude with the patients, wherein the clinician has been very, I don't know, has not given time with the patients. But if that has been your experience, you can move on to the next mental health professional. There are a lot of amazing mental health professionals that are available. It's a process of trial and error. And once you find a good professional, I am sure things will improve. It's necessary to show a bit of patience. And I think we can do a lot of difference to people with bipolar disorder. Yeah.
Thank you so much, Dr. Kaneenica and Dr. Alok, for sharing your thoughts about the AI stuff and the research which is going on. It's definitely very encouraging. And I think there are a lot of takebacks which we have done today. I'm sorry to the audience that we have overshooted our time a little, but definitely there was a lot of learnings from both the mental health professionals. So thank you very much for joining us and sharing your learnings and expert advice to us. Thank you so much.
Thank you. Thanks a lot.
Thank you.
Thank you.